Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to dive into another 3 Vivas for CICM Fellowship exams. So, Maddie, before we dive into today's episode, how's things?
Yeah, things are good. I think congratulations everyone who's recently finished the fellowship exam.
The requirements or demands of the fellowship exam has definitely changed. So, I guess please let us know if in any form or shape we can help you in getting over that hurdle. So, yeah, again, congratulations to those who passed and also people who couldn't pass the exam. More than happy to help in any form or shape. So, let's dive into today's Viva. 55-year-old female with no reported comorbid conditions has been admitted unexpectedly to your tertiary care intensive care unit from the operating theater. Now, she had an uneventful general anesthetics for a total hip replacement. 45 minutes later, she was found unrousable by the attending nurse. An ABG showed a pH of 7.01, PaCO2 of 110 millimeters of mercury, PaO2 of 100 millimeters of mercury on 15 liters non-rebreather mask with lactate of 1.1 and base excess of only plus 2 millimole per liter. She was urgently reintubated and transferred to your ICU. She's hemodynamically stable, and you're asked to give what's your most likely differential diagnosis in this patient.
So this shows a patient with hypercapnic and an element of hypoxic respiratory failure. And I think broadly we can think about it as a complication of the anesthetic itself, a new pathology or an exacerbation of a chronic disease, although it says she has no reported comorbid conditions, but it might not be diagnosed or she might not have self-reported. So in terms of the complication of the procedure or the anesthetic, it could be drug-related, such as dose-related change, including things like excess narcotics given intra-op or in recovery, or inadequate reversible paralysis, a drug error such as accidental administration of neuromuscular blockade or atropine overdose, or an adverse reaction to a drug such as things like sucks apnea, a transfusion-related lung injury, a drug interaction, a high spinal if she had an adjunct spinal with the GA, but I would also generally accept that hemodynamic instability with this, or something like that's much less likely, like malignant hypothermia. Other complications could be negative pressure pulmonary edema, a fat embolism, but would expect hemodynamic instability again with this, an aspiration event or a pneumothorax. In terms of new pathology, it can be anything that causes a decreased level of consciousness and hypercapnic respiratory failure. So things like intracranial lesions like an ischemic or hemorrhagic stroke, a PE, AMI with APO, or a metabolic cause such as hypoglycemia, or an exacerbation of chronic disease such as COPD, cardiac failure, obesity, hyperventilation, because thinking about why she's needing a hip replacement at the age of 55, or underlying renal or hepatic failure, which is slowing the elimination of drugs such as opiates, and less likely things like a thyroid storm or an exacerbation of myasthenia, like a myasthenic crisis.
Yeah, that's right. So I guess obviously this is the first presentation with hypercapnic respiratory failure. So you need to have a really broad differential diagnosis and then obviously walk your way through structured approach. So how would you further evaluate this patient in order to exact cause for her deterioration?
Sure. Like with any evaluation, it involves a targeted history examination and relevant investigations. So the history would mainly be targeted towards the anaesthetic and recovery details and her background history. So from an anaesthetic point of view, I'd like to know her vital signs and the trends during the case, and what was her neurology and respiratory function when she was extubated, as in was this a change or was she extubated sort of deep? Any medications given during the case and in recovery, including the timing of things like opiates, neuromuscular blockade, whether reversal was given, any blood products given, and whether there was any neuroaxial adjunct such as spinal anaesthetic. And any operative details or complications during the operation itself. And in terms of her background, I'd like to know the reason for her hip replacement, any regular medications, allergies, smoking or drug history, and any family history of adverse reactions to anaesthetic. From an examination point of view, I'd like to assess her neurology, depending on whether they had to give her further paralysis to re-intubate her. But if any lateralizing signs or focal deficit, her pupillary size and reaction, and do a train of thought to look for any residual paralysis. her cardiovascular status. So we know that she's currently hemodynamically stable, but does she have any arrhythmias such as AF, which might increase the risk of things like ischemic stroke? Is she tachycardic, her fluid status? And from a respiratory point of view, the oxygenation and ventilatory support that she's currently requiring, and signs of any underlying lung pathology, so any wheeze, decreased air entry, crepitations, and any signs of chronic disease. So this includes things like her body habitus with significant obesity. Does she have any signs of chronic cardiovascular, respiratory, or renal or endocrine disease? And then other things such as looking at the signs of fever, which would, potentially consider things like malignant hypothermia or a thyroid storm, muscle rigidity, whether the surgical site looks okay. And then finally coming to investigations, it'd be about bedside bloods and imaging. So from bedside point of view, I'd like to have a repeat ABG to evaluate her gas exchange while she's intubated, her metabolic parameters, her sugar and electrolytes, an ECG to look for things like arrhythmias like AF, any ischemic changes or signs of right heart strain, and consider things like an echo if there's concerns of any sort of intraoperative cardiac event. From a blood test point of view, I'd want to know what her renal function and liver function tests were, see if there was any underlying impairments, and her full blood count for her hemoglobin. Depending on my previous evaluation, think of further, more specific blood tests such as a CK and coags for things like rhabdomyolysis and DIC, a troponin for ischemia, and thyroid function tests. Imaging, I'd want to have a chest X-ray to look at her ATT position and for any signs of localized pulmonary pathology, such as aspiration or pneumothorax, or signs of chronic lung disease, such as hyperinflation. And if her neurology was not improving, and do a CT brain to evaluate for intracranial pathology.
Okay, so let's say in this patient, you're suspecting there is some sort of residual paralysis from the anesthetics. So what are the kind of potential methods for assessing signs of residual paralysis?
So there are two broad categories of methods, which are clinical tests or neuromuscular tests. So the clinical tests, there are several, but we know that they all cannot reliably exclude residual paralysis. So these clinical tests include things like the evaluation of breathing, so things like a vital capacity of greater than 15 mils a kilo. However, that vital capacity can even be normal with a trainer 4 ratio that's 0.6, which is still abnormal. Recovery of spontaneous breathing, which is also not reliable, can be present even when peripheral muscles are incompletely paralyzed. A maximal inspiratory pressure of greater than 25 centimeters of water, and a normal EtCO2, which again are both not reliable. Other tests look at clinical tests of neuromuscular function, so sustained head or leg lift, which is the ability of the patient to lift their head or their leg against gravity for more than 5 seconds. And this corresponds to a trainer 4 ratio greater than 0.4 to 0.7, but they might be influenced by other things such as pain, medications, and it's again not sensitive. Grip strength, so a sustained hand grip for 5 seconds or more, or the tongue depressor test, which is an ability to hold an object between the teeth while someone removes it for greater than 3 seconds. And this is the most reliable clinical test, which corresponds to a trainer 4 ratio of greater than 0.8 to 0.9. The neuromuscular tests are thought to be more reliable, and these are qualitative or quantitative. So the qualitative tests are using a trainer 4 and fade measurement, but only looking at using the clinician's judgment by the feeling the muscular contraction or looking for the trainer 4 twitches. There's also double burst stimulation or post-tetanic count, which you can see there's more information in the show notes. And then there's quantitative tests, which are the gold standard and detect even smaller amounts of residual blockade. And they generally quantitatively analyze the trainer 4 numbers and the ratio. These include things like electromyography, accelerometry, kinesiomyography, and mechanomyography, where there's more details on this in the show notes as well.
Thanks, Peri. You mentioned about a trainer 4. Can you explain how does trainer 4 work?
So trainer 4 is a way of monitoring the degree of neuromuscular blockade, and it uses a nerve stimulator to transcutaneously apply supramaximal stimulus, which is in the form of some sort of current, to a peripheral nerve. We often use the ulnar nerve, and then measuring the associated muscular response. So in order to minimize the resistance of the tissue, we need to make sure the area that we're applying the electrodes is clean and remove excess hair. Then 2 electrodes are placed along the nerve pathway. So, for example, if we're thinking about the ulnar nerve, the negative electrode, which is the black one, is placed at the ulnar border of the wrist at the flexor crease, with the positive or the red electrode placed approximately 2 centimeters more proximal parallel to the flexor carpi ulnaris tendon. So the nerve is stimulated with 4 single twitches, 0.5 seconds apart at a frequency of 2 Hz, and then the associated muscle response or twitches are noted. For the ulnar nerve, this is the adductor pollicis or thumb adduction, which is assessed. And then the number and amplitude of observed twitches decreases with increasing neuromuscular blockade. So T4 disappears first, followed by T3, T2, then T1, with recovery occurring in reverse. And then we can look at the number of twitches and correlate that with the amount of blockade. So if there's no twitches thought to be 100% blockade, whereas 4 twitches is less than 75% blockade. We can also assess the amplitude. So this is the ratio of the amplitude of the first twitch, T1 to the 4th twitch, and this is known as the trainer-4 ratio. So when a non-depolarizing neuromuscular blocking agent is given, there is a reduction in the amplitude of the responses, with T4 being affected first and T1 last, and this is known as fade. When we think about the trainer-4 ratio, this is actually really important and things that anaesthetists consider about in terms of adequacy for extubation at times. So a trainer-4 ratio greater than 90% is now thought to be adequate for extubation, whereas previously we thought it was a trainer-4 ratio of greater than 70%. When a depolarizing neuromuscular blocker agent is given, this is the pattern of this trainer-4 is a bit different. So the 4 twitches are decreased equally in size, so there's no fade. But if repeated or larger doses of these depolarizing agents, such as SUCs, are given, a phase 2 block develops where it exhibits some features of non-depolarizing agents, such as fade.
Thanks, Mary. So now some candidates might ask why we are asking trainer-4 in the fellowship exam. And I think in the recent exam, there was a question about the pulse oximeter or arterial transducer. So there is not such thing as the question are meant for fellowship versus primary. The syllabus is going to be covered any of the exams. So just be prepared with these monitoring questions, because at the intensivists, you are expected to know how each monitor works, and that if that comes in the fellowship exam, it's not a unreasonable question to ask.
Yeah. And I think it's also something we use semi-regularly, like for patients that are paralyzed, or we ask for it. I have before for patients who come back from theatre who aren't waking up appropriately. So I think it is something to know about and know how, like, at least some of the basic principles about.
Yeah, that's correct. So I guess the next question is about the consequences of this residual neuromuscular block.
Yeah, so we know that studies have shown that actually residual neuromuscular block is an independent risk factor for anesthetic-related 24 hours post-operative morbidity and mortality, and that critical respiratory events or adverse respiratory events were more common if the trainer-4 ratio that we just spoke about was less than 0.7 in recovery, and that it's associated with increased morbidity and mortality in the post-operative period. So potential risks include things like this lady has, like hypoxia, hypercapnia, acute respiratory failure. It can cause airway obstruction, and you might be more risk of that in patients who are obese or elderly. Atelectasis, aspiration, difficulty swallowing or speaking, patient distress if they have, it's weakness and residual paralysis. And there's an increased requirement for post-operative ventilation, ICU admission, and it's associated with longer stay in recovery. And then obviously the very severe consequences that can result, including hypoxic brain injury and death if it's not recognised and treated appropriately.
That's correct. So thanks, Maddie. So let's move on to the number 2 Viva for today. And this is quite interesting Viva. This is on the evidence-based medicine. And often this Viva is tricky to answer. So the first question is, what are the strengths and weaknesses of a non-inferiority trial?
Yep. So I think evidence or statistics is probably like a lot of people's least favorite topic. But I did a bit of a dive into this one. So non-inferiority trials aim to show that a treatment is not worse than an active control by more than the equivalence margin. So they compare a new treatment with an established standard of care. The null hypothesis is therefore that the intervention is worse than the control by greater than or equal to the non-inferiority margin. So strength of this is that it doesn't require a placebo group, and this might be advantageous, especially when having a placebo group is unethical. It allows cheaper, more convenient or less toxic therapies to be introduced in the place of older therapies. And it might be considered when the experimental treatment is unlikely to be superior to the established treatment or that the current treatment is highly effective. So then in terms of the weakness, it doesn't actually prove the efficacy of a tested therapy. It relies upon known or accepted benefit of the control. And we know that then both treatments might actually be similarly harmful, and it needs to be performed under the similar conditions in which the active control has demonstrated benefit. Also, we know that there's no clear consensus on what margin of non-inferiority or what the equivalence margin that should be accepted is. And repeated non-inferiority trials might lead to gradual acceptance of inferior therapies, which is a phenomenon known as bio-creep. Furthermore, we know that as medicine is continually evolving, conditions and practice may have changed since the original placebo trial that was used for the current standard therapy, or there may never have been a placebo-controlled trial to begin with. Things like the data analysis and equipoise are more complex with non-inferiority trials, and in general, they require a larger sample size compared to superiority trials. Also, we know that a poorly conducted study gravitates towards non-inferiority. So examples include non-adherence to allocated treatment, which might dilute the treatment effect in the control group or result in similar treatment effects measured in both groups. If the study has non-specific endpoint measures, if there's inappropriate participant cohort that's chosen, or if there's insufficient follow-up, all of these things might gravitate more towards concluding non-inferiority when in fact it was just a poorly conducted study.
Thanks, Mary. So recently we've covered this trial called as PACER trial in our eCrit Care podcast, which is also a non-inferiority trial. And this trial compared the efficacy of prophylactic platelet transfusion for CVC insertion. And as you rightly said, usually this trial design is used when you cannot use the placebo. So you compare the new treatment with the current standard of care. Well, obviously, the issue is about the non-inferiority margin, as you mentioned, and that almost leads to sometimes underpowered study. But also, what type of analysis you use is important. So if you're going to use intention to treat analysis only, then often that's not sufficient. So you need to probably perform intention to treat and per protocol analysis both, and also one-sided alpha versus two-sided alpha. So often you need to do two-sided alpha statistical test in order to decide the significance of the results. So there are a few nuances in doing non-inferiority trial, and often they are considered inferior trial design to your superiority trial designs because the superiority you're doing the placebo-controlled randomized controlled trial. So it's complicated, but you kind of covered all the strengths and weaknesses quite well there. So what is the difference between a non-inferiority trial and an equivalence trial?
So equivalence trials aim to show that a new treatment is no better and no worse than the standard treatment by the equivalence margin, whereas a non-inferiority trial aims to show that it's no worse by the equivalence margin. In other words, an equivalence trial aims to show that a new treatment is not unacceptably different compared to the standard, whereas a non-inferiority trial aims to show that it is not unacceptably worse.
Okay, so moving on to another trial design, what is an adaptive design clinical trial?
So this is a clinical trial design that allows for prospectively planned modifications to one or more specified aspects of the study design, which can occur after the trial's initiation based on accumulating data from subjects in the trial, and this does not undermine the validity of the trial. So examples of planned modifications that could be included in an adaptive design trial include things like pre-specified stopping rules for efficacy or futility. So this is in things like group sequential designs, adaptations to the randomization procedure or allocation ratio. So, for example, if the randomization ratio is changed to favor the treatment arms with highest probability of being superior, such as in adaptive randomization trials, adding or abandoning treatment doses or arms, such as in multi-arm, multi-stage trials or platform trials, adaptations to the sample size, such as in sample size re-estimation trials, or adaptations to the study population, such as adaptive enrichment trials. And there was a whole question, I think, in the last paper on platform trials, and it's becoming much more commonly used kind of trial design.
Yeah, that's right. And I think the classic example of adaptive trial design in intensive care is REMAP CAP and recovery trial. And that trial during the COVID was quite amazing because obviously gave us a very clear efficacy results around which drug are going to be useful in the same patient population. So I guess platform trial, as you said, is going to be the new trial designs which coming into fashion now. It has been tried in a different kind of setting like cancer drugs, coronary care settings, and it's been quite widely adapted in those specialties. And now I think the intensive care is also leading the way in these design trials. So what are the advantages and disadvantages of these adaptive design trials?
So in terms of the advantages, they're generally less expensive because they're often of shorter duration and are more efficient with fewer patients needed. It gives us the ability to identify ineffective or effective treatments earlier, so hopefully maximising patient benefit. And therefore, it might assign more patients to more promising treatment arms. So this good ethically may maximise potential benefits and minimise exposure to ineffective or harmful therapies for the majority of patients. In terms of the disadvantage, it's a way more complex design and statistical analysis that needs to be used. It can introduce bias. It's less understood on the whole, and it may increase the risk of type 1 error, which is the rejection of a true null hypothesis, especially if things like it's stopped prematurely, that can increase the risk.
Great. So thanks, Maddie. So let's move on to the third Viva for today. You are working as a locum intensivist in a regional hospital with no tertiary pediatric service. You're called as a part of the trauma team to ED to assist with the management of an 8-year-old child with burns. The paramedics report that the child was found semi-conscious and breathing in downstairs hallway of a home which was set on fire less than an hour ago. Can you please describe your initial assessment and monitoring priorities for this child?
So my initial assessment and monitoring priorities would involve using an EMST approach to obtain a target history, perform a primary and then a secondary survey with specific considerations regarding potential need for early securing of the airway, given higher risk of airway compromise in children, use of the Broslow charts to calculate medication equipment requirements, and early liaison with a tertiary paediatric centre with the aim for early retrieval to a centre with paediatric burns experience. So in terms of the history, I'd like to know briefly from the paramedics about the burn, including the exact time of the burn, any signs of other trauma, any first aid or treatment given on the scene, such as running the child under cold water, and the vital signs and trends during transfer. And then in terms of the patient, whether any history of other illnesses, allergies, medications, their last meal and the tetanus status. Then I'd like to conduct a primary survey, which would involve concurrent assessment and management. So I would want to evaluate for signs of airway burn and inhalational injury, especially because he was found, at a house on fire and semi-conscious. So looking for things like stridor, facial burns, singed nasal hairs, and considering early intubation if these are present, keeping in mind the potential difficulties in securing airway in children, and ongoing repeated evaluation of the airway, as well as protecting the C-spine if there was concerns or signs of associated trauma. I'd like to optimise his respiratory monitoring and oxygenation, so apply high flow oxygen, have SATs monitoring, and evaluate his respiratory status with respiratory rate, breathing pattern, breath sounds, a chest X-ray, and looking for signs of injuries and chest burns, especially circumferential burns, which might need escharotomy. In terms of his circulation, optimising the monitoring, so ECG monitoring and non-invasive BP, and inserting an IDC and NGT if there's greater than 10% burns. Obtaining adequate access in bloods, including 2 points of IV or IO access, taking blood such as a full blood count, UEC and VBG for carbon monoxide, lactate and glucose, and a group and hold, and evaluating and optimising the circulatory status, which would involve looking at his general appearance, capillary fill, skin colour, and vital signs, giving a 10 to 20 ml per kilo bolus of IV fluid if there were signs of shock, and looking for other causes of shock in the setting of potential trauma, such as bleeding, pneumothorax, or a cardiac contusion. Depending on the amount of burns, if it's 10% or more, fluid resus with the modified Parkins formula, which is 3 mils per kilo total body surface area using Hartmann's, and the first half of the total volume given over the first 8 hours. And this is in addition to the maintenance fluids, which should be fluids with glucose. And then evaluating and managing the burns. So calculating the extent of the burns, which is important to weigh the patient and use age-appropriate London Browder chart or the Palmer surface method. looking and treating circumferential burns with monitoring their neurovascular status, elevating the area and providing espirotomies if required, and very early liaison with the burns team at a tertiary hospital, which might include taking photos or with consent, debriding clearly loose or blistered skin and apply appropriate dressings. And then evaluating the consciousness and neurology. So in the kid, it's mainly using an AVPU score, looking at pupillary response, any focal neurology, especially if there's any peripheral neurovascular compromise or limb burns, checking the blood sugar because children are prone to hypoglycemia, and if present, give 10 mils per kilo of 10% dextrose, and optimizing the analgesia. So this will involve paracetamol 15 milligrams per kilo, as well as generally, depending on the extent of burns or other injuries, an opiate, which can be intranasal fentanyl or intravenous fentanyl or morphine. And from an exposure point of view, it's monitored full exposure, including a log roll to examine the back to calculate the percentage and depth of burns, as well as to look for other injuries, using cling wrap to wrap if there's no definitive burns dressings available, and to optimize the temperature, aiming normothermia, because children are more prone to hypothermia, especially during the initial resuscitation. So covering as soon as possible, warming the room and warming fluids, and providing a tetanus immunization. And then finally, from a logistics point of view, liaising with and updating family if they're present or not injured, and liaising early on with a tertiary paediatric centre with a burns team and retrieval regarding transfer of this patient.
That's great. So what are the methods of calculating the total body surface area affected by burns in this child?
So the gold standard is the age-appropriate London Browder chart, which is available online, the most accurate method, and has different age ranges. The Palmer method can also be used, but it's generally more effective for smaller burns. And this uses the size of the patient's hand, which includes the palm and the fingers, to estimate the burn size, and a Palmer surface approximately equals 1% of total body surface area. In adults, there's the Wallace rule of nines, but this is inaccurate in children due to proportionally larger head and smaller legs. But there are some facilities, like I've seen some American hospitals, that have a specific rule of nines chart for children of varying ages. So depending on the institution, this might sometimes be used.
Thanks, Maddie. So last question is about the airway in kids. So what are the anatomic airway differences in children compared to adults, which make their airway management a bit more complex?
So children have a prominent occiput compared to adults. So when lying supine, the neck is flexed, which is not the ideal position for laryngoscopy. So often they need more of a neutral position, or like a towel or roller under their shoulders. They have a smaller mandible, so mouth opening is reduced, but larger adenoids and tongue. So this increases the risk of obstructions and makes it more difficult to visualize the normal airway structures with a laryngoscope. As well as that, their airway structures and soft tissues much softer compared to adults and less rigid. So they're more prone to trauma with laryngoscopy, and it's easier to obstruct their airway completely with things like cricoid pressure. They have a longer, floppier epiglottis. So sometimes straight blades are used, especially in infants. And this epiglottis projects into the airway more than it does in adults. Their larynx is also more anterior and more superior, so it's often opposite C3 to C4 versus C4 to 5 in adults, which may make laryngoscopy more difficult. Their trachea and their airway are narrower, and it's more easily obstructed by blood, secretions, edema, and things like external compression, such as if they have airway or like neck burns. So even relatively little narrowing can rapidly increase the airway resistance and work of breathing. And this also makes cricothyroidotomy more difficult. They also have a shorter trachea, so it's much easier to accidentally intubate their right main bronchus. And the narrowest point in their airways is the cricoid cartilage, which is below the vocal cords, compared to adults where the vocal cords is the narrowest point.
Thanks, Maddie. So that's the end of our today's episode. I can see probably you got some question for me there.
Yeah, I do. So what did they name the placebo-controlled randomized control trial, which was run on Halloween?
Oh my gosh. No, I can't think of anything, Maddie.
Trick or treatment.
This is way beyond my alley. Another failure for me. So, thanks, Maddie. So I guess I'm not going to see you for a while now. So will be back in a few months' time with this fellowship episode. Wish you all the best and congratulations in advance. So I guess we will keep the listeners updated once you come back.
Yeah. Hopefully it won't be too long, but we'll see.
Fingers crossed. Again, well done for all your efforts and contribution to this podcast. But I will looking forward to catching up in few months' time.
Yeah, and good luck everyone sitting next time. Keep up the hard work. You'll get there in the end.
Yeah, that's right. And again, massive thanks to Maddie for her all selfless contribution to teaching in both primary and fellowship world. And she deserves a big break now for a very good reason. So enjoy.
Thanks, Swapnil.
So that's the end of our today's episode. We'll be back, as I said, in a few months' time. Till then, goodbye and have a nice time.
Thanks for listening, and we'll see you next time.